Thank you very much for for that intro, Marianne, and a warm welcome to all of you who are joining us from all corners of the world, if you will. If I look at the participant list and if I look at the names across here, you know, it's really heartwarming to see, well, that some of you have woken up early, some of you are staying late, some of us are somewhere in the middle of the day, but we are all expectantly waiting to engage in this webinar. Now, the title of the webinar is Global Challenges, Local Context, and the COVID-19 Vaccine. And we particularly want to look into issues of innovations around pandemic preparedness and management. Now, as the clip might have given a hint, we are doing this under the auspices of the CEPGIM program, which brings together these great institutions from Central America, from Africa here, and from Europe. And my colleagues who are a core part of this team are here. Maybe I will give them a couple of minutes at the end, but they could just wave if their videos are on. I can see Andrea Prado from INCAE. I can see Magda from IESE. I can see Steve from Wharton. Who else can I see? I can see Nuria, or rather I can see her name, and a few others who are not here. But anyway, today is not about us. It's not about the CEPGIM program. Today we have an excellent panel to come and share with us and give us their insights around this interesting topic. Thank you so much, those of you who are participating, those of you who've already sent questions ahead of time. The way we plan to run this webinar is we will have a brief discussion in the beginning, and then we are going to lay out quite a bit of time for us to be able to engage and see how much of your personal interest questions can be addressed throughout the webinar. And so, because I truly cannot do great justice to each of these very special individuals by attempting to introduce them, I am going to just call them out by name and ask them to introduce themselves. As you might have seen from the invite, we have Helena from London School, actually, and from the independent panel. I think that is a hat that she's wearing this evening, or morning, or afternoon, depending on where you are. We have Jaime, the Director of Global Health Sciences at UCSF. Also wears many hats, so he'll tell us which one he's wearing today. And we have Walter from here in Nairobi. So what I will do is maybe apply the rule of, is it ladies first and men just before, or how does it go? Or we just stick with ladies first?
I'm okay with ladies first.
Okay, so let me allow then Helena to come in, and just Helena, if you could just briefly introduce yourself and then introduce the work of your institution in this space, and then we can take it from there.
Many thanks, Ben, and good afternoon, good morning, good evening to everybody. I'm super delighted to be here today to share the experiences of our work. And I think I'm going to wear 3 hats today because as I know from Magda that she's very keen on innovation. So I'm going to try to share in 5 minutes innovative ideas in many areas, not only on vaccines. So I'm an associate professor at the London School of Hygiene and Tropical Medicine, and I'm also an associate professor at the National University of Singapore. And of course, Singapore is very well known for innovation, not so much on vaccines, but on many other areas. And then finally, you see here on the big slide, the independent panel. This is, so I do a lot of work on health systems resilience and global health. And of course, in Singapore, the moment that the pandemic started, the dean of our school said, can you please all leave everything that you're doing and focus on doing research on COVID-19. So that was like an honor and a pleasure to be able to all my team to work on that. And very early on, we started working on health systems resilience in terms of Asian countries and what other countries could learn from that. And slowly on that, I started publishing a few papers. We were quite fast because, of course, Singapore was one of the countries first hit by the pandemic. And then through the work that we have conducted, I was honored to be asked to join the independent panel, which, if you're not aware, this is WHO member states asked Dr. Tedros to arrange an independent assessment of the pandemic exploring the international system, countries, but also WHO. And this, for me, this I think is the first innovation in a way, that this is a first, there's other panels that they have been done, but perhaps not so thorough as this one. But I just want to, because I know that the topic is on vaccines, but I wanted to give you this idea of the independent panel. And later on, I will discuss some recommendations that we've provided overall and some more focus on vaccines. So just to mention that with the independent panel, it's been a group of more than 20 people and the panel members working over 8 months non-stop, and we've had collaborators all over the world. With one of our key collaborators here today, Jaime, who conducted 2 very thorough analyses in Mexico and the US. And I was responsible for managing the assessment of 28 countries. So the COVID responses in 28 countries. So this is, if you want to ask questions around that, I would be very happy to answer. But moving into the topic of today, I think just a general overview. So I think the good news or the best news in this pandemic, if we can say that there was a best or good news, is the fact of the vaccine, the innovation and the historical achievements. And this slide, I think, really represents that if we look at the pathogens and linked to disease and how long it took to develop a vaccine, I think all the experts that I had kind of more in terms of conversations, like, are we going to get a vaccine? I think most of the experts were hesitant that we would do it so fast. So I think these we all have to acknowledge and remind ourselves that it has been a very, very clear success. And you can see there, COVID-19, SARS, like the time space has been very little from identifying the pathogen to developing a vaccine. That was the good news. The not so good news has been now, we've been excellent at developing the vaccines, but we have not been so good now at all the other processes. And this map, it's the sad story, which highlights when the vaccine is going to be available, when are most likely to reach, and you can see the red are the countries that will get the vaccines at the later stage. So this is not very good news. And in the independent panel, we do identify why this is happening, and these are, sometimes we forget about it, it's a lot to do with political processes and the lack of leadership. And here, just to highlight that when we discuss later that all the areas that we've been looking at, it's a complicated process. So it's not only about developing a vaccine, but all the processes involved here. And an area that I wanted to highlight maybe later for the discussion that sometimes we forget, it's all about vaccines where they are produced, but it's important to look at the manufacturers of vaccines, but also who manufactures the components. And you can see there's a very inequitable distribution of that also. In our panel, very key inequalities, and that's what we're trying to address. And of course, what this leads to, you can see here in the slide, is North America and Europe having more population vaccinated and some other continents not doing so well. So I think the staggering and I think a bit of a shameful statistic is that only 0.9% of people in low middle income countries have received at least 1 dose. So in our work, we're trying to identify what didn't work. And I'm going to leave this for later because I've been told by Ben, don't give all the answers from the beginning. So I'm going to hand over already. And here, what I will let you know later is what we identify as the key problems and then some of the recommendations, because we really try to provide actionable recommendations so we can solve the problem in the future. And the key message in our report was actually the headlines, because it was published and it was everywhere. I mean, I was a bit scared when I saw the key headline was the pandemic could have been prevented. So I will tell you more about that. But the other second very key message very quickly that came afterwards was it could have been prevented, but now we can prevent the next pandemic. And these are the recommendations that I was referring to. So on that note, I already hand over to you, to Ben, and I can go through the recommendations later.
Okay, thank you. Thank you very much for that, Elena. And I think that is a very good context setting, giving us a very broad view of COVID-19 and the vaccine story. And I think maybe this would be a good chance for me to invite Walter to then introduce himself and what he has been doing. Again, like you, he wears very many hats, CAVI, Gavi. He'll tell us what all these acronyms mean. And then also tells us what he's doing and his perspective of this vaccine concern, all right? Okay, so over to you, Prof.
Okay, thank you very much, and good evening from my part of the world, and good morning in other parts, and good day for others. So my name is Walter Jaoko. So I am a professor of microbiology. I teach at University of Nairobi, and I also direct a research institute at the University of Nairobi called CAVI, Institute of Clinical Research, which started as an HIV vaccine research institute, but has progressed to do other infectious diseases research, including drugs and vaccines and other devices that are used for treatment or prevention of infectious diseases. I also sit in the expert committee on clinical trials. That is the national regulatory authority for Kenya. So any vaccine that comes into the country has to be approved by this national regulatory authority called the Pharmacy and Poisons Board. I have also an interest in ethics, particularly clinical ethics, both research and clinical ethics. And so I teach that also at different fora. So I think I'll stop there and just say that I have a very deep interest on vaccines because that is what I've been doing for the past 20 years. Thank you.
Excellent, thank you. And I think, you know, at a later stage, I'm going to ask you specifically, Walter, whether and how well the current vaccines that we have in the market, how well they answer the key questions. As Helena has mentioned, you know, this time round, the blue dot and the red dot, did I get the colors right, Helena? We're very close together. In fact, you know, so, and the question is why? Why so close when all the others were very far apart? So hopefully you'll be able to unpack that for us, because as some of the participants were commenting earlier on in the questions that they sent, this is one of the reasons that is making them hesitant, you know, to go for this vaccine. And that is one of the things we want to address. Anyway, let me not get carried away. Jaime, please.
Hello, Ben. Thank you, everyone, for inviting me here. My name is Jaime Sepulveda, born and raised in Mexico, where I did most of my career. I am a medical epidemiologist by training. In the last 20 years or so, I have been in the United States working at the Gates Foundation, and for the last 10 years at the University of California, San Francisco, leading the Institute for Global Health Sciences. I'm glad Elena started mentioning this incredible work of the independent panel, because I think it has been very influential and describing what are the main challenges that we face and what are the recommendations for moving forward. I was invited by the independent panel to lead a group to study and assess the response, the performance of two countries, the US and Mexico, because those two countries were among the worst performers in terms of response to the pandemic. So that was a very useful experience. We spent 3 months working nonstop, and we made a number of recommendations for each one of those two countries based on evidence after a very, very detailed study. So the bottom line is that there are commonalities among the countries that did perform very poorly. And one of those, Ben, has to do with leadership and management, which is so critical for the discussion we're having today. So leadership, it is clear that countries led by right-wing populist men do very poorly. And we have seen that in the UK, in India, in the US, in Mexico, in Brazil, where a pattern of denial, a pattern of giving preference to the economy than to saving lives, a pattern of arrogance led to a delayed response and a poor performance. So I think there is a pattern here of poor leadership that has enormous consequences. The management issue is also important. We can see that the rollout of vaccines in those countries have been also poor, given not only lack of supply, and I will get back to what are the impediments for a good rollout of vaccines, but strictly to management. And in the case of the US, in the Trump administration, and in Mexico, in the current administration, we have seen that poor management is also, along with poor leadership, the main reason behind a poor performance. I will get back to other hurdles in the rollout of vaccines later in the conversation, Ben. Back to you.
Yeah, thank you. Thank you very much. And you mentioned very, very important things. And just before we get to the issue of the rollout, there's first getting to a good understanding of what this is that we are talking about. And so this is where I want to revert it back to you, Walter. The whole question around the current vaccine scenario, okay? From the participants, there's still a lot of confusion. And when you read the gray literature, okay, there's still a lot of discussion. We have AstraZeneca, we have J&J, we have this one. Should I mix them? Should I not mix them? Why? What exactly does this mean? So could you just sort of lay out that landscape for us very, very briefly on the current vaccine situation, and whether, if we plug this to that very, very rapid development that Helena talked about, whether the current vaccines actually do answer what we expect in terms of safety, efficacy, etc., etc. Walter.
Okay, thank you. Thank you very much. So vaccine development is a process. Usually starts with animals. One of the ethical requirements before testing a product in human beings is that it should be tested in animals. And this is based on ethics that in the past, during the Nazi atrocities, there are a lot of things that were done to human beings, that there have been now regulations to ensure that whatever is tested in human beings, first of all, has some level of safety. And unfortunately, that animals are the ones that are still used, including small animals and big animals. But before you see any product like a vaccine tested in human being, it has gone through safety testing in animals. And in human beings, we test it in 3 phases. The first phase is the focus is on safety. Then the second phase is only the vaccine that you find to be safe in human beings in what we call a phase 1. And that is monitored very, very, very closely to ensure that nothing serious happens. And they have a lot of stoppage rules to ensure that nothing adversely serious happens to human beings. And phase 1 usually tests it in very few numbers of people because you don't know the effects that you're going to see in human beings. You have some idea because you've seen what has happened in animals, and it's only mild things like maybe losing appetite, having a mild fever that disappears, and so on. Then the ones that are safe in phase 1, what we call safety, then you take them to safe 2, where you include more people, and there the focus is looking at the dosages, where you compare different dosages to see how it works. But you only tell that a vaccine is actually effective when you do phase 3, which is a large number of people, and that is why it is tested in several countries. You want to include as diverse a population as possible, people with different disease conditions. For example, for this HIV, for the current COVID, you want to see whether it is safe to use it in people with different conditions, HIV negative, HIV positive, heart diseases, and so on and so forth. But even when you do in phase 3 is when you're able to answer the question, is this vaccine protecting? But remember, after that, it will be used by millions of people. So you've only tested it in, let's say, 40,000 people, which is a large number to do a study on. But now when you roll it out, you start seeing some of the things that were not visible in that number, just because there were fewer compared to now using it in millions and millions of people. Now, it is good to assure people that all the vaccines that we have at the moment under emergency authorization have gone through that. I've seen in some social media, people who are anti-vaccine saying, oh, the stages were jumped. It was not tested in animals. There are no phase 1 studies. That is not true. All the vaccines that you see have gone through that phase. As to whether then we can be able to say that they are completely safe, we are not able to do that because of what we have said. The data that we have is based on phase 3 trials in thousands of people. So there's some things that we might start noticing that had not been noticed before. But that is not unique for COVID vaccine. All the vaccines we've ever been given were tested that way. And there's some things we just started noticing much later on. I'll give you an example. There's a vaccine called the rotavirus vaccine, which prevents death in children because of diarrhea. And it was used for a long period of time before they certainly realized that it was associated with some intestinal problems, and it was stopped for that reason. So it's not unique for COVID vaccine. What I would want to say that all the vaccines have been tested, have been shown to be safe up to phase 3 trials. And now we are using them out. As we roll them out, we'll be able to see some things that were never seen before, like the blood clots you've heard of in AstraZeneca vaccine and in the Johnson & Johnson. So we are closely monitoring. Once you start rolling it out, there is something called pharmacovigilance. And anything that happens to somebody who has been vaccinated during the rollout is correct. The information is collected and analyzed to see if it is an additional information. Somebody asked in one of the questions, which vaccine is the best vaccine? And I would say the vaccine you have access to is the best vaccine. All of these vaccines have been shown to prevent development of severe disease that require hospitalization, that will lead to death. The percentage of how much they prevent you from getting disease, infection, that is the variation. So some are very good in preventing infection compared to others, but that is not the key objective of the vaccine. What we are aiming at is to prevent severe disease that requires hospitalization, ICU, admission, and death. I think I'll stop there. Thank you.
Thank you so much, Walter. Now, my question is, with all these good things that you've said, I mean, about the vaccine, there is still quite a lot of hesitancy, and drawing just from the experience here, the government had to step in. Initially the prioritization was for frontline health workers, and other categories, but they were simply not taking this. And the question is why? Why still this hesitancy when there's all these good stuff that we know about vaccines? And I don't know, Helena, and Jaime, from your experience in these multi-country things, is it the same thing out there as it is here in Africa? People don't want to go for the vaccine?
You want to go first, Jaime? Or?
Yes, I think it is not the same in every country, Ben. In the US, the hesitancy is manifested mostly in some population groups. It's interesting that counties and states that are mostly Republican are in the US are those places where there is larger resistance to vaccination. I have not seen much resistance to vaccination in Mexico and most of Latin America as a consequence of a political position, as it happens very much in the US. Republicans are very much behind. And in fact, you can see in the US by zip code, what is the proportion of people, eligible people that have been vaccinated. The Institute of Health Metrics and Evaluation just came out with that information. And it's very clear how there is a correlation between vaccine hesitancy and political affiliation. So that is one of the main reasons, but there are other reasons in terms of access and also, I think it has to do with certain population groups in the US. Hispanics and African Americans have been more resistant for vaccination, not necessarily because of a political position, but because they have to work, because they are not informed, because they might be undocumented and are afraid to go to get a vaccine and being arrested. So there are other factors. Don't think that everything is related to skepticism on the vaccine itself. Of course, there are many conspiracy theories circulating in the social media here in the US and other places as well that we need to combat with information. Back to you, Ben.
And it is interesting that you mentioned that idea of social media, because for some reason, what is going on in the social media seems to influence a lot more our decision making than many things. But Elena, let me bring you in here, and you say your piece. Then maybe you can also tackle these information issue or communication issue. You know?
Yeah, definitely.
Okay, over to you.
Yeah, so I completely agree with Jaime's assessment. And I think what we've learned with looking at the vaccine hesitancy, that it's also not only linked to politics, but also historical. So we've seen that some countries, we've done some surveys, and we can see that countries that they already had hesitancy towards vaccines, other vaccines, they still have it for COVID. So an example would be France. So that they're having more challenges to vaccinate because of the historical aspects of that. But the one key area, and I think in Europe overall, it's been quite well received, the vaccine. But even in my own country, in Spain at the beginning, it was a bit political. You could see that the right wing, it was a bit more like, oh, we don't trust the government. But very early on, when we could see the data coming up from the UK and how effective it was very much. I mean, now it has gone up to 90% of acceptance. So the key here is, because we've seen different countries, and this I think it's very context specific. So I think it's a country, you need to explore what are the issues in each of the countries. And what we always argue is that we need to develop risk communication strategies. And the countries that have been more successful have been those that have developed strategies to inform the population. We're talking about communication, taking into account what you said, Ben, taking into account social media. But it's very, very important that we need to include the population and the community and the target groups in the planning of those strategies. And this, for me, has been a complete failure in COVID-19. Only a few countries, particularly, a huge failure in Europe. So I think African countries and Asian countries have taught Europe a lot of lessons, and one of them is that involving the community much more. There's very good examples in Thailand of involving the community in the planning of strategies. And by that, I mean organizing focus groups, involving the younger population, what type of messages are the ones that the population wants to receive for the information to be well received. And those campaigns that have been, we call them unidirectional. So the government is telling the population what to do. They have not worked so well. But it's a complex area because social media complicates everything also in terms of developing an appropriate strategy. Over to you, Ben.
Or the other way around, maybe it is time for the WHO and other global actors to develop a better social media strategy.
That's true.
to counter this. Walter, what is the experience?
I think, Ben, so the thing about here, so at the moment, actually, hesitancy is not the problem. At the beginning, it was, but as you know, people are looking for these vaccines and they're not getting them. So at the beginning, and my personal view is the social media. And at the beginning, what I found very interesting, and as has been indicated by Jaime, a lot of the social media messages that were reaching this part of the world were from the conservative, Republican, anti-vaccine lobby groups. And that is what people started getting at the beginning. And that is what contributed to the hesitancy. And what made even the healthcare workers in this part of the world be hesitant at the beginning was that a lot of these were people who were medical. And they passed the message as if these vaccines have not been tested, there is a hidden agenda that is targeting resource-limited countries. There are people who want to finish you. There is agenda to depopulate the world, and they're starting with you. So that was the message, and that is why I'm saying I'm agreeing with Helena that unfortunately we were not prepared to counter that messaging. So at the beginning, a lot of hesitancy was based on social media with a lot of false information. But as people started seeing others taking the vaccine and nothing happening to them, more and more people started looking for this vaccine. And now we have a challenge. You can't get it. The demand is just more than the supply.
Mm-hmm. So in brief, what you're saying, hesitancy is now not the problem. The problem is access. Bringing us, to what, and this can feed well to Jaime's earlier promise, bringing us to the idea of rollout of these vaccines. Okay, we did talk about the politics and the production. I think I was waiting sort of like for a third P, Helena, but you didn't give me a third P. Good things happen in threes. So Jaime, tell us, what are the impediments from where you sit for a good rollout of these vaccines, assuming that skepticism is not an issue anymore, so our problem now is how to get, when we will get them. And you had a very illustrative map, Helena, I recall, 2023 and something like that. Jaime, over to you.
Thank you, Ben. Let me give some context because I think there's a philosophical concept that is useful here. Mm-hmm. In 1989, there was a terrible measles epidemic going through Canada, the US, and Mexico. The Canada and US did well. Mexico had 6,000 children who died of measles in that winter of 1989. Why? Because social and economic determinants. So clearly, that led to the universal vaccination program in Mexico. And the philosophical concept then was immunological equity. All of the children, all of the vaccines. That is the only one health equity that we can achieve rapidly, immunological equity. And I think the biggest single challenge we face in global health right now is to achieve COVID immunological equity in the world. And frankly, it is right now a huge disparity between rich, middle income, and poor countries. There's a gradient in terms of vaccination coverage by gross national income. And I think that is a huge social injustice and also a real threat for the rest of the world, because no country will be safe until all countries are safe. Mm. So I would say that the number one impediment is, of course, supply. The world is not producing rapidly enough vaccines for everyone in this planet. And we need to achieve practically 8 billion people needing 2 doses of vaccines. So producing 16 billion doses of vaccines plus syringes and all of the other elements in the chain is quite complex. So that won't be happening anytime soon. That is the number one impediment, supply. Cost, of course, that is also an impediment. Vaccines are not cheap, at anywhere between $4 for AstraZeneca up to $20, $25 for the mRNA vaccines. Multiply that by 16 billion, it starts mounting. Of course, compared to the economic consequences of not vaccinating, this is a bargain. This is the single most effective, cost-effective intervention we have in our hands, and we're missing a huge opportunity. The next impediment is cold chain. Some of the vaccines, as we know, the mRNA vaccines require ultra freezing, and that is something that not every country has in hand as part of their cold chain mechanism. Finally, I would say that everything related to management, including transportation, human resources, and all of the other supplies that are needed, needles, syringes, etc., is one of the other challenges and hurdles we face. By when can we aim to have immunological equity? Frankly, Ben, I think that if the G7, the G20 countries are serious about making a difference, it could happen by the end of 2022 if we make a real commitment to make it happen. So it is doable. It requires political will in a big scale, and of course, economic investment. But I would say the argument here is not only a humanitarian one in terms of vaccine justice. I think you can also say that it is for global health security, because as long as people remain unvaccinated, new variants will emerge that for which vaccines might not be effective in the future. So it's in our best interest in terms of national security to achieve immunological equity everywhere.
No, thank you. You speak to very, very deep points there. Helena, I don't know if you want to add something to that, or
yeah, I'm happy to follow up on that because it follows very nicely for the recommendations of the independent panel. So completely agree with the challenges and the assessment of Jaime. This is exactly similar to what we wrote in our report. But then one of the issues, Madame Shirley, particularly the previous president from Liberia, Nobel Prize winner, she was very keen on us having actionable, she kept on insisting, give us actionable recommendations on vaccines. And we actually came up with urgent, actionable recommendations. So what we were saying is that those countries that can afford it and that have produced more vaccines, and we even counted how many, I mean, we tried to look at contracts, and some of the members of the independent panel had access to that information. So in total, the highest income countries have secured themselves 200% of the doses for the vaccine, so double what they need. So what we are telling them is they have to donate at least 1 billion doses by September 2021 to COVAX. And we wanted to create this urgency because this report was going to be presented at the World Health Assembly. Then Madame Shirley and Helen Clark are really good at doing all this. I mean, I've learned a lot working with them at doing these negotiations. And it was like a starting point for countries to start donating. We were very happy to hear that the US, after our report, committed to donate 500 million by 2022, so that does not solve the problem. And we were just to share with you a bit in confidence, we were very disappointed with the G7 in terms of the doses that they decided to donate. But not only one, there's another recommendation, and maybe we can talk a bit about that, which is the most challenging one. I think in global health overall, there was a shocking announcement made by the Biden administration in terms of patents. So that's also something for us to mention. We were all like, oh, wow, this was never going to happen. So even we were in the middle of writing the report and we were like, this was unexpected. So what we suggest, because there's also some issues in terms of how fast this can take place, our urgent recommendations is for WTO, WHO, manufacturers to meet urgently and to come up with an agreement of voluntary licensing. And if they don't come up to an agreement in 3 months, we suggest that they should waive patents. So this is a huge debate. This was a very bold recommendation, but Madame Shirley and Helen Clark are very much in touch with the head of WTO, and it's being considered. So these are the key 2 areas, besides other more long-term recommendations like funding, creating a global fund, and also elevating health to the United Nations. But on vaccines, these were our 2 recommendations, urgent recommendations. We are still optimistic, but we thought especially the G7. We thought they were going to make a stronger statement on that.
Yeah.
Over to you, Ben.
No, thank you very much. Because there are two things there. There's the idea of the production of these vaccines and therefore addressing, the cold chain issues and the management of that process. But then there's also something that was interesting here, if I can now piggyback on the questions around that, because when you think about health systems, so you have always this trade-off, the so-called iron triangle, the quality, cost, access issue, which can also apply here. But then if you put innovation at the heart of that triangle, then you can be able to sort of adjust all the three items of quality, cost, and access very, very well. So the question then becomes, what kinds of innovations are we seeing out there? And how can we fast track these innovations? And maybe, I can see a question from Steve here that is directly, on innovation as being a mechanism through which, Africa can leapfrog some of these things. Okay, so that is talking about innovation maybe in the production arena. But I am looking at these innovations spanning the entire, spectrum. As you mentioned earlier, Helena, innovations even in terms of how we communicate, how the focus groups were done, so that you can increase a little bit more of the legitimacy and the acceptance, and then moving that all the way. So I rephrase my question. How can we fast track innovations for, and not just COVID, any kind of pandemic, preparedness and management, based on some of these lessons that we have learned? Maybe I start with you, Jaime, because you provoked the conversation on innovation, and then we can hear from Walter. Mm-hmm.
Thank you, Ben. So I'm glad you're pointing that there's a whole spectrum from discovery, development, and delivery, the triple D, I would call. So innovations in discovery relate to vaccines, which are just incredible how fast this happened, but also in diagnostics. We had good diagnostics pretty rapidly after the isolation of the virus. I think we have lagged behind in innovation in drugs. That is related to the discovery and maybe part of the development. But I think in the delivery part, there are many things that need to be addressed. And you did mention communication. I think that's a critical one. I would like to point out, if I may make a quick digression here.
Go ahead.
I think there's long debate about whether to have vertical programs or horizontal programs. Should COVID vaccination be a vertical, isolated, or should that be integrated into other primary healthcare discussions? And I think there is a lot of room for innovation in the delivery part, because I think that the dilemma of vertical versus horizontal is the wrong kind of debate. In COVID, we will need to go vertical first. There's no way around that. Yeah. But it would be foolish not to think that we need to integrate eventually COVID vaccine among other vaccines and other highly cost-effective public health interventions. And that is what we did in Mexico as a different approach to vertical versus horizontal. And we called it the diagonal approach, by which we chose the most highly cost-effective interventions to be integrated in a proactive delivery form. And I think that made a huge revolution in terms of delivery innovation. And I can speak some more on that, but back to you, Ben.
Okay, thank you. Walter, innovations, what are you seeing? What are you seeing out there, or where,
Yeah, so innovations are good. I think I like what Jaime is saying. At the moment, because of the pandemic, this is a crisis that we are in. The innovation we require is, how does the vaccine that we already have in hand reach to the people who need it? That is a shorter thing, shorter term. In terms of innovation, in terms of manufacturing vaccine, that takes time, and it will not address the current pandemic. It is important for future pandemics, but for the current pandemic, it is the distribution of these vaccines. How do they reach to the most remote parts of this world, majority of which are in resource-constrained countries? So that is where the innovation is. But then, backed by that is that the developing countries need to start putting infrastructure in place to be able to manufacture vaccines that they'll be able to use, not just for pandemics. I mean, we don't manufacture vaccines even for measles, for diseases of childhood that we have had for years, for many, many, many years. And now at the moment for Africa, I can say there are initiatives that are beginning to think around this and coalescing several countries into regional vaccine development initiatives. Just today, my university was launching an initiative started in South Africa by the Walter Sisulu Foundation, asking them itself the questions, what can we do together? There is a lot of strength in people working together to develop vaccines that we can be able to use for regular childhood vaccine illnesses. What Africa is also facing that is making this urgent in a way is that many of the African countries are beginning to move from the low-income countries to the lower middle income countries, like Kenya, for example, and Tanzania. And when you do that, you stop getting vaccines from Gavi, the Global Alliance for Vaccine. And so you have to start buying it. And why would you be buying it if you can manufacture it regionally and get it at a much cheaper price? So there are certain motivations for African countries to start thinking innovatively about developing their own vaccines. But unfortunately, the innovation in the context of developing a vaccine will not address the current epidemic.
Mm-hmm. But there is a starting point, because just to go back home with an institution that you may be familiar with, the Kenya veterinary vaccines, I think it was called Kevevapi, the program, was very good with animal vaccines, and they produced quite a bit, but somewhere along the way, they lost their way, yeah? So we could have some sort of starting point in terms of infrastructure and build from that. The other thing that you are asking on the issue of supply, I think, some of you will agree with me that we only need to ask Coke or Pepsi how they do it. Because somebody was saying that even in the Sahara, you can get a cold Coke.
Yeah, that is true. But then Coke and vaccines are quite different. The infrastructure required, the cold temperatures that has to be maintained. But we can learn from them. It's true.
Agreed. Helena.
Yes. So a couple of issues. Yeah, or in terms of manufacturing, so they keep on going back to the recommendations, but I think they might be useful. One of our recommendations is also to develop regional hubs. So of course, Africa should have its regional hub, Latin America, which are not existent right now. In terms of innovation, sometimes, because lately I see myself, because I've been writing some papers on health systems, resilience, and analysis of 28 countries, and I remember saying, nothing that we propose is new, because we already know what should happen, but it's just not happening. And I remember when I shared it with the press, with the Spanish newspaper El País, he sent me a message saying, you sell very badly your paper. You should say that everything is new and everything is innovative. But sometimes I was like, oh no, but I was trying to make the point that we do know the answers to what we need to do. It's just not happening. So in terms of vaccines, the interesting bit for me was that I kind of predicted, and sometimes I've been wrong, although I don't make it normally vocally try to predict the future, but I predicted that for vaccines, Europe, for example, was going to be much better than Asia in terms of distribution of vaccines. And that was merely based on the fact that primary healthcare is very strong in Europe and it's very weak in Asia. And a lot of the providers are private providers, and that complicates a lot the distribution of vaccines. Whilst Spain had done very badly in the COVID response, I mean, we have very strong primary healthcare. The same for the UK, very strong nursing profession, and I thought this is going to be easy for Spain to do. And it's having that system in place and showing how primary healthcare works. We have the Almata Declaration, 78, yes, I mean, it's not new, and also the fact of having universal health coverage. Having said that, for vaccines, it was very clear, but we were quite disappointed with the COVID response, and this we're still trying to give an answer to that, how those countries that had universal health coverage did not do so well. So that's a big question mark. So you have the Spains, you have the UKs, you have countries with strong universal health coverage that did very poorly, and there's other reasons. But for the vaccines, we believe that having a strong primary healthcare public system, well coordinated with a nurse, good human resources, nurses that can provide the vaccine, has been very, very successful. Over to you, Ben.
Thank you. And I think, you know, we've been having this conversation amongst the four of us. I think it's a good opportunity now to invite the participants, although I have been rephrasing their questions based on what a number of them had sent earlier. But let me open it up so that they can ask you themselves. So I don't know, anyone with a hand up, anyone with a specific question? If you could put your hand up and I can call you out so that you can activate your mic. As we are scrolling through, I see, Steve, you had a couple of questions. Maybe you could throw them out here.
I've, because I didn't want to interrupt the discussion, I've just been adding some questions to the chat, which I'm sure everyone has followed. I had a couple to Walter specifically, having to do with production and helping make maybe some linkages. You know, I think that's what it gets down to. I am aware, I'm actually advising the African Development Bank on these issues of pharma and vaccine production. Interestingly, the African Union recognized almost a decade ago that this was a serious security problem for the continent and issued some directives on that, but very little activity has transpired, and some of the development financial institutions now are trying to address it, recognizing that this is, as Walter was saying, for not only the next pandemic, but for vaccines and essential medicines that we already know we need. So that's where my questions were, and you know, Walter answered them in turn. But this question of what is going to be necessary? Well, first of all, can we leapfrog? And if so, what are the preconditions or prerequisites for that? I think that's a really important question, and the World Economic Forum is doing a lot of research in that area as well. So that wasn't a question, but it was more of a speech. So I'm sorry.
Not to worry. I'm happy that you are engaging with Walter on the side, so that is good enough. Pratap, I see your hand.
Yes, thank you. This is a fascinating conversation, but I'd like to pick up on those last points that Walter and Steve have been talking about, because that's been troubling me quite a bit, that there has been, 20 plus years and certainly more than that of investment into clinical trials infrastructure in Africa. But what was really shocking is the number of those trials, the number of COVID-related trials that are even now happening, not just vaccine-related, but even broadly COVID-related health trials in Africa. So it's really tiny despite so much investment in clinical trial infrastructure by the NIHs and the Wellcome Trusts and so on. And so the question is, what might happen differently going forward? Why should we be optimistic that there is going to be much more clinical trial, or this infrastructure that we have right now is going to be the foundation for what's going to for the next 20 years, or what needs to change if it hasn't worked this time? And this is probably to both Walter and Elena, and probably also to Jaime. But Walter,
thank you. I think it's two-sided coin. I wouldn't say that it has not worked. We have a malaria vaccine that is currently being rolled out. It's not as good as we would have expected. It's one of those diseases that has been very difficult to get a vaccine. The vaccine for malaria trials, the trials for malaria vaccine were conducted in Kenya, Tanzania, Burkina Faso, and all that, because we have the infrastructure. And based on those trials, the vaccine we applied for registration, and now it is being used. It's been shown that it prevents deaths in the young children. And that is the first step. We are hoping that they can improve them. The science of malaria vaccine is very, very complicated. And that explains part of the diagram that Helena showed. It's just that the pathogen, the disease-causing pathogens are also very different. There are some that are very difficult to get vaccines for, just because they keep on changing. In the life cycle of malaria, you have like 14 antigens, unlike what you see for COVID, for example. And so different diseases have challenges. There are some vaccines, there are some diseases that we've been looking for vaccines for years, and we have not been able to get, malaria just being one of those, and HIV being the other. So the pathogen itself has its own issues. Although the efforts that were put in COVID vaccines is unprecedented. Governments put in a lot of money to be able to get this vaccine because it was a pandemic. Every government in the West was trying to invest in something that can prevent it. The Ebola vaccine, my institute conducted trials on the Ebola vaccine. So the vaccine that is being used, that was developed by Janssen, we participated in those clinical trials. So there is a good story that African countries have participated in trials and developed products that are currently being used. Now, part of the problem we also have in Africa is the politician. You remember when COVID started and we were talking about conducting clinical trials, the politicians are telling their people not to be involved in those trials, that oh, this thing is risky. You know, my own president said that the COVID vaccine trials were not going to be conducted in Kenya. And so there is a problem. There is a political problem as well. And what we need is to educate our leaders to also appreciate the importance of participating in clinical trials by their own people. So right now we have these vaccines that are being rolled out. There are very few African countries that took part in it. It's only South Africa and Kenya. And Kenya came in the AstraZeneca vaccine fairly late, but there's no other African country that was involved just because of politics. So there are more issues that need to be addressed going forward. Thank you.
Okay. Thank you. Thank you very much for that response. Magda, I see your hand is up.
Yes, thank you, Ben. Great discussion. It's really fascinating to follow you. I would like to ask a question in more general terms on, particularly to Elena and Jaime, but maybe also to Walter, on what are the learning points, or what would be the things, the good practices or the best practices that we can share. What have you seen in countries who say, wow, this worked really well? And Elena, you made a great point on every country is different and there's a different cultural context, etc. But would there be maybe part of the recommendation or part of the things that you have seen and say, well, this is actually something that we would recommend in terms of how to get the current stage of the pandemic, which is to get as much vaccine out as possible, but also in view of a future pandemic and preparedness for the, well, hopefully not so soon, but for future pandemics. Thanks. Elena, you might want to start.
Elena, this is directed, I think, to you first.
Yes. So we've done an analysis of, as I said, for the independent panel on 28 countries, and what we wanted to focus was on the worst performers and the best performers on COVID-19. It was a very complex analysis. And what we identified was first that there's some contextual factor that, as Magda mentioned, I think if I remember properly, your PhD was exactly on that, on context, the importance of contextual factors. I still remember. So what we realized
very
is that
good memory.
We realized that first of all, prior experience on pandemics was key, and that in our report it was highlighted that actually some of the key institutions that have done better, and we praised them in the report, is Africa CDC for the work that they have done. And a bit not putting to shame, because we have to be very careful and very politically correct, but we were saying that in this pandemic, African countries have done much better in general, and Asian countries. Much better than European countries, and also than North America, and then also than Latin America. When we say prior experience, it's prior experience and introducing the structures needed. So prior experience was not sufficient, and I think this is the key example of Mexico, and maybe Jaime can say on that, but because Mexico having prior experience was not enough. It was also having prior experience, developing the appropriate structures, and also having the right leadership. So you could have the two key things, but if you didn't have the right leadership, also it didn't work. In terms of course, in terms of coordination, we identified that having leadership that the population could trust, and then also having a well-coordinated approach, and that could be at the national or regional level, but the coordination had to be key. And of course, acting early. And that has been one of the key challenges. We assess that countries lost 1 month. Most of the countries in Europe lost 1 month in terms of responding to COVID-19, with the exception of Asian countries and also some of the African countries. So we've done a very complex analysis. I mean, there's a lot of things there, but I think the key for us was acting fast, having the right leadership, and also having the right coordination. And then also very important, especially management. And this has been very absent in the analysis, is all the management structures that need to be in place. And those countries that, for example, they were very bureaucratic, they had bigger challenges. Or those countries that where bureaucracy could not challenge leadership also had lots of challenges. And just to give you an example, so I had the privilege to interview people in the 28 countries, the leaders that were leading the response. And I think the two most impressive interviews I had were in New Zealand and in Liberia, or Nigeria also. So New Zealand, Liberia, Nigeria, where the responses, when they were describing what they did, I was like, so New Zealand was acting fast. We were not, when we heard what was happening in China, we decided to close down because we did not have a very strong health system, and we did not have very strong public health measures. So prior establishment was not key, and they were like, the leadership was listening to us, and very important, everybody was working together and in a coordinated manner, and everybody helping each other, and we were contesting the leadership. The leadership allowed us to do what the science suggested. So also following scientific advice was key. So they've been a bit long, but I just wanted to give you an overview of all the factors that they were successful. And we have a paper now under review in Nature Medicine. Hopefully we'll come out soon on the countries that did well and the countries that did not perform so well. Over to you, Ben.
Good luck with that, Elena. Jaime has been scribbling furiously. So Jaime, tell us what your recommendations, what your learning points, what are the big things?
Maybe Ben,
and the little one.
If I could just add on this, Jaime, you mentioned like the leading by the old men. We have actually in the beginning of the pandemic, I always put the women-led countries.
But Magda, really?
So
Want to go there?
Yeah.
Well, seriously, this is not political correctness. This is a true conviction and belief. Female leadership has proven in this COVID pandemic to be a determining factor. You can see that in New Zealand, in Germany, in Taiwan, in Norway. I mean, the contrast with neighbor countries is just amazing. That tells you that we should really have more female prime ministers and presidents to do much better in the world. I believe that.
Jaime, you are killing my
case of-
ambition here, but carry on.
In the US, I think we have a natural experiment in leadership. The shift from the Trump administration to the Biden administration is night and day in terms of response to COVID. I would say that lessons here, I agree with Elena. Acting early and aggressively is key. This is for me my fifth pandemic: HIV, cholera, H1N1, Zika, and now COVID. In every single instance, I have seen that acting early and aggressively is the key factor in a condition, in a communicable disease that grows exponentially. The sooner you act, the better you will do. Asian countries did very well in non-pharmaceutical interventions. Mask use in Asia was much better, and I think it did have a huge impact on the response. Those societies trust their government, and their governments gave good advice in terms of social distancing, in terms of lockdown, but also in testing, contact tracing, and isolating. That is a lesson we can learn from Asia that we did not do well in the Western Hemisphere. So I think those are some of the lessons that we can apply everywhere for this and also for future pandemics.
No, thank you. Thank you very much, Jaime. And just to add another example, which I'm sure will delight Magda, we also saw quite the shift in the change in leadership in our southern neighbor, Tanzania, was also night and day. Walter, am I speaking the truth here?
Yeah, you're speaking the truth. And what Jaime has actually said is an observation, a very interesting observation. Yeah, so our neighbors in the south, immediate south, denied the existence of COVID for a very long time. They even said they were not going to use vaccines, but then when a lady took over, things just changed, and now they are giving vaccines and messaging about prevention of COVID. So totally agree, Ben.
Okay, fair enough. All right. Thank you very much for that intriguing question, Magda, because it gives us a very nice context to begin wrapping up the conversation. It's a very interesting conversation. There's still a raft of questions that we could have explored, but we've run out of time. And so if you will allow me, then you know, I would just ask for some last any parting shot. Maybe I could start with you, Walter, here, and then we end with whoever is at the apex right now. I'm told the women are at the apex. So Helena, you'll close this off for us. So Walter, Jaime, and then Helena. Any parting shots for us?
Yes, I think just in summary, I think the world has to realize that an epidemic needs to be controlled everywhere, as we've rightly said, that if you only focus on your country, then you're not doing much. It will come back, and it will come back in a big way. It will come back in variants. And so it's in the interest of the global community to control this COVID everywhere, and not just in the selected countries.
Thank you. Thank you very much, Walter. And that is very well said. The idea of vaccine justice and immunological equity, as Jaime had put it. So Jaime.
Yes, I think we need to think ahead. Given vaccine nationalism, and it's understandable that countries that produce vaccines want to apply those vaccines in their own populations first. I think it's understandable but it's short-sighted. So we need to think differently. And that is what I would like to see, a real radical change in the global health architecture. I don't think we can have the same WHO or the same global fund and the same multilateral global health agencies we have as if nothing had happened, business as usual. We need a radical change. And I would like to see, among other things, regional centers of excellence, independent, to get rid of vaccine nationalism so that vaccines could be produced in East Africa, in South Africa, in Brazil, in Mexico, as regional centers in different places in Asia to make sure that we have all of the existing vaccines available for regional populations and have a system by which vaccines could be interchanged and shared as a global public good. It is a global public good. So I think we need to think very differently from this one. And it would be a huge missed opportunity if we let this crisis go and not make it an opportunity for change.
Okay, thank you. Thank you very much, Jaime. Very well said. Helena,
Yes.
we all made reference to your recommendations. We had stopped you somewhere in the middle. So this might be a good place for you to sort of like just pick points from there and wrap it up for us.
Yes, but I just wanted to highlight, because I have here in capital letters, global public goods, paradigm shift to say. So completely agreeing with Jaime. This is I'm not copying you, Jaime, I have it written here, the importance of having that, I think, as a shift in mentality. And this is exactly what we also insist in the report. And this is why we are suggesting a mechanism, global funding mechanism, where countries have to put money every year, and then from that fund, then you do what you suggested, Jaime, these regional hubs and these investments. But it has to be a central global funding. This is a funding facility that we are suggesting that it has to be a new one. In terms of a radical change, I would say radical change because we are suggesting to elevate health beyond the WHO. And this one, I must confess that in some circles has not been very well received. So I think that's good news. If it's not well received, it means that maybe it's a bit of a radical change. And it's this idea that we suggest that WHO is great, but maybe decisions are being made by ministers of health. And it's this idea of elevating health to a global council, which would be a newly formed not institution, but a kind of a mechanism. And there we're suggesting that the head of states should be present. And this is, again, now it's about politics and the leadership to really engage on them. And so far, we know Antonio Gutierrez has been very positive on that recommendation. Angela Merkel also supports the Global Council, and the Biden administration also supports it. And also the president of South Africa. So I was thinking, like, in my naive understanding of politics, I was like, that's it, who else do you need? But apparently not. So now what we need to do is we're asking for a meeting in New York to discuss the Global Council. But in terms of what we're discussing about global public goods, just to highlight that as a final point, that after our report, it was considered that there was a need to have an extra World Health Assembly. And for all of you to know, that's going to happen in November. So that's a key deadline to all look at if these recommendations are going to be implemented or not. And the key aspect here is it's going to be that, because it's another key recommendations is introducing a framework convention on pandemics. And that's key, and it will be the second time that WHO has ever done it. So if Tedros manages to agree on a convention, and this type of issues we've been discussing today will be included in this framework. So this is the one I would say for everybody to watch out what happens in November. And then if we manage to succeed, to have a meeting at the highest level. So that's all from me. Thanks a lot.
No, thank you. Thank you very much. And I think that is a good wrapping up of our conversations. So there's a lot that we could have covered. So I must apologize to the participants if there was any particularly unique thing that we didn't address. It is my fault, not the fault of the panelists. And it's also the fault of my watch, which keeps on ticking once we pass the time. All right. So Professor Zelena, Professor Walter, Professor Jaime, thank you very much. Muchas gracias. This is deeply appreciated. This was done under the auspices of the Business School Alliance for Health Management, BAM. And all the institutions, we have a number of institutions, the representatives are here. Andrea, Magda, I can see who else is here. I can see Steve, myself, and others. So this was done under the auspices, but within that, we have a small group of us that is trying to champion this idea that you all brought out on leadership and management. And we're running a program that is called the SEPGIM, okay, Senior Executive Program in Global Health Innovation Management. And the primary focus of that is really on the leadership and management part, as well as on the innovation part. And so, we hope that we'll also be able to do our thing there in trying to help address some of these global health challenges that we are talking about. Leadership and management is key. And now maybe our leadership conversations need to take on a gender lens, it seems. If Jaime is to be believed, all right? So, thank you once again, everyone. Do have a good day, a good evening, or a good night from where you have.
Thank you.
Bye-bye.
Thank you. Goodbye.
Thank you all. Bye-bye.